Welcome to Paltub Academy. This is Sinus Lifting Techniques from A to DIVA, Part 3, the Percrustal Sinus Lifter Evolution. I am Alejandro Berg, oral surgeon from Universidad de Chile. I'm located in Santiago de Chile and have been a specialist for the last 25 years. So I hope you'll enjoy this. And well, let's get on with it. These are my emails and WhatsApp number, phone number. If you ever need to contact me, I'm always willing to help and always willing to talk. So please do. So basically, this is what we did with the lateral sinus technique. This is a piezoelectric animation. And basically what we did is flap, the making of the window, separating the window from the bone and most likely keeping the bone attached to the Schneider membrane, using the elephant's foot with a high irrigation to make the initial separation of the membrane, and well, periostal elevators to separate the membrane to a position, and then, as you can see here, grafting, compressing membrane, sutures, and basically that was that. And if it only were that easy. So this is an animation taken from a Korean company, and it shows a variation of the lateral window technique based on high diameter trephine or a dome-shaped coarse diamond burr. This system is, I've used it and it's quite effective. You have to be very aware of the marks in the trephine and of course the contact of the drill with the Schneider membrane in order to preserve and not to injure it. And then this companies present you with this dome-shaped periostal elevator. I call it membrane separator, and you do the initial separation of the membrane either with the bone or without the bone, and then you have these other parts of the kit. I always try to separate from mesial and apical to most lower and distal in order to preserve as much as possible the membrane. And then you have sequential longer membrane separators, those that you should always have in contact with the bone in order to avoid pinching and injuring the membrane. That could bring us some problems in the future if we don't notice it. And well, longer membrane separators that allow you to get into the internal wall of the maxillary sinus, and after separating the membrane, you proceed with the grafting. In this case is an allograft, and after grafting and packing, that helps separating and keeping the membrane up, comes the time for the implant installation. By no means I would recommend a liniment burr, but that's it. And you place the implant and then initial healing screw, which is, well, flat in this case. And after that, you should notice that the grafting material rearranges itself around the implant. You place a membrane and stitches, and that would be that. And so we're finally here. This is the summers osteotome sinus floor elevation and implant placement technique, presented in 1986. And the development of this technique was in parallel to the lateral window technique, completely separated with a completely different approach. This is a sinus floor elevation technique by plastic compressive deformation, and there is no contact between the osteotome and the Schneiderian membrane. This allows you to gain height by deforming plastically the remaining bone and compressing the surrounding bone in order to gain stability. But there is no real contact between the dome-shaped osteotomes and the Schneiderian membrane, which means less post-op complications, better post-op actually, and very small incisions with very small blood flow disruption, so less complications. And this was the idea behind this: less complications and good initial stability. This is a list of variations of the percrystal sinus lift techniques, and these are some of the techniques I've selected that show improvement over prior deficiencies or shortcomings that may have been around in prior techniques. And it shows that we're always trying to change things, solve problems. And this also shows that although we've been doing this for a long, long time, there is always somebody trying to do something new that could be better. Also, I can see here there is a flow or a directionality towards less invasive, more easily predictable techniques. And the last years, we've been seeing a mobilization or a tendency towards controlled hydrodynamic and hydraulic forces to lift the membranes, as you will see. And with that said, we will review some of this, not all, but it will show some changes in the ideas, the basic ideas behind this. But before we go to the list, we should ask why. Why do we change? Why did we do percrystal sinus lifts? And well, the answer is not really very easy, but to summarize, it would be less invasive, less traumatic, and that represents a better case acceptance, which is really good for us. And also, since this is less invasive, you have less changes in the sinus architecture, which physiologically is actually very good because it helps or speeds up the healing process. Also, there is a limitation or a complication when you have to extract and do a simultaneous lateral window sinus lift. You will disrupt the pink aesthetics, and it would be complicated to fix it later. So either you let it extract, let it heal, and then do the lateral window, or you are forced to do soft tissue grafts and create secondary morbid sites and, well, whatever. So the idea behind this technique is that you can extract, do the sinus lift, place the implant without disrupting the pink aesthetics, which is actually very, very good. The most technically complex part in this type of sinus lift is achieving green stick fracture without perforating, tearing, or traumatizing the membrane. And so when you displace your disc, if you have a disc, and you create a cavity, you can fill it up, and the membrane will act as that separating membrane that allows your material to be contained and not flow inside the maxillary sinus. And we take this risk doing it blind because it's actually less risky than doing a lateral window, which is much more disruptive in terms of sinus architecture and blood flow, and of course, physiologically for the maxillary sinus. And having said that, this is far from being a risk-free technique. There are several complications that can arise from it, which are in different degrees of complication, but the most common when you do osteotomes and hammers, it's the benign paroxysmal vertigo, which will probably resolve itself in some time, or you can handle it with the Epley's maneuver, and it will become nothing more than a nuisance, but is there, and you have to warn your patients because it will bother them. And having said this, this is a reason, one of the reasons why we have evolved towards hammerless procedures, either manual or mechanical. And we'll see in the next slides the advantages of this kind of techniques. Now, in 1992, the osteotome sinus floor elevation and implant placement was presented. A technique without contact with the Schneider membrane, but with the use of concave osteotomes that allowed not only compressing and deforming, but the installation or the adding of graft material. So this is truly a volumetric height and compression technique. So we can speak of a true sinus floor elevation with gaining. And this was designed for simultaneous implant placement. As we saw in the earlier slides, there's no real contact between the instruments and the graft material with the Schneider membrane. So the membrane is actually not submitted to great stress. But in future developing techniques, the Schneider membrane will be in contact with instruments or displaced largely. And so the biomechanical properties had to be studied. And so we probed and we stretched and we compressed in order to achieve a set of parameters which would allow us to install these techniques in a predictable manner without tearing up or bursting the membrane. And we discovered we can stretch it at 125%, and the force needed to separate it from the cortical floor is actually quite low, ensuring that we can produce this separation without bursting and having our graft contained. As I said, we studied and we probed and stretched and compressed, and actually we get something like this. This is a detachment force graphic, and it shows that having a white base, you can detach and elevate your membrane up to 8 millimeters with a very little force applied. If you see on the left side, you can get to 8 millimeters with under 4 newtons, which is completely between safety margins of the stretching of the membrane. And you will get, you see the red line and the green line, and they show that you get more height the wider your osteotome is. And that will allow you not to perforate the membrane. Lots of studying for these conclusions. Having acquired knowledge about the biomechanical properties of the Schneider membrane, Summers presented the FSD, or Future Site Development Technique, in 1995. This technique was designed for much less bone remnant, and it moved a block of the base of the maxillary sinus, placed graft, and in a second stage surgery, you could place your implants. It was designed with trephines and osteotomes. But you will see that the concept is absolutely correct, and it will be embraced by other techniques later. And so based on that, this is what we used to do. Small H flap, drilling up to the cortical, a little graft material, and using the osteotomes to displace, and after some working, the implant placement. As I said before, the progrestal or transcrestal or internal sinus lift is perfectly suited for post-extraction situations like this one. So we do the extraction very carefully. We do the sinus lift, place the implant, do the graft, and we will preserve the pink aesthetics and the alveolar contour in order to attain the most aesthetic restoration in the end. In '98, Bruschi introduces the localized management sinus floor elevation and implant placement. What a name. And basically what he does is tries to separate the cortical part of the sinus floor and move, displace vestibularly in order to gain volume, also without touching the membrane, induces a little fracture of the floor and places the implant without graft in one time. And so, of course, Summers in '99 replies to Bruschi with the bone added osteotome sinus floor elevation, the BAUS. Wow. Lots of vocals here. And basically what he does is he takes his original technique, adds some Bruschi on it, and adds graft material and places the implants using the bone discs that remain attached to the sinus membrane in order to gain tenting effect for his graft material. And this would be the live version of what we just saw. Small H flap, exposure of the ridge. There are 6 millimeters remnant, so drilling in order to not overuse of the osteotomes. Sequential drilling in order to expand the cortical, as we know due to the graph we saw earlier. The wider the osteotome, the lighter the force you need to separate and detach and elevate the membrane, so less possibilities of tearing up or burst. So sequential drilling in order to widen the osteotomy as much as possible, and then osteotomes, concave tip osteotomes with stoppers, and the idea is to produce the infracture or grain stick fracture of the sinus floor using the hammers as light as possible. And once we have checked that, we see that the osteotome can go through, we place a little graft material initially to make what some people call mattress or the cushion. And then with the osteotome, we pack it up slightly and slowly and easy. Take care. This should be done gently. And well, after packing all the graft material, implant placement. I do it by hand. This is torque speed by the handpiece, but notice the stability of the implant, and that has to do more with macro geometry and design than the technique first per se. After attaining final stability, notice very high stability, and this is the X-ray of the implant with the graft. Close the implant, sutures, and basically that would be that. Later, some companies like this one presented hammerless techniques. Small H flap, X-ray determination of the height, initial drilling shy of the cortical bone, probing to correctly assess the depth, longer drilling, longer probing, and drilling up to the Schneider membrane, and then probing again to make sure. So then when you do, you go back a number with a stopper and you start to widen your osteotomy up to the maximum. And then with the packing system using stoppers, you pack your material, elevate your membrane slowly and lightly until you're done. And when all the graft is in, all the graft you want to place is in, final drill, and then your implant, primary closed lid, and suture, and you're done. And again, once more, well, in this case, Fugasoto says, you know what, I can do this. I can place implants after extraction sites with immediate sinus lift. So he devises this technique with a trephine where he cuts and separates the septum, and using osteotomes and graft material, he deforms and compresses the cortical floor in order to attain implant stability from the tip of the implant and longer implants, of course. And so he includes adding material, plastic deformation, compressive deformation, and of course sinus floor elevation without touching the membrane, neither the trephine or the osteotomes. And that is the key to this technique. Do not touch the membrane. Trephines are deadly to membranes. And so this technique was devised for one-time surgery, I mean, graft and implant placement simultaneously. And so we arrived to the year 2000. Yeah, change of the millennium. And of course, somebody else said, in this case, Dr. Kossi, I can do better. I have a better idea. So I take a trephine and get up to the cortical floor, and with a specially designed flap burr, I create a bony disc that remains attached to the maxillary sinus membrane. And these special burrs have lateral holes that inject lots and lots of fluid and separate the membrane initially from the maxillary sinus floor. And then through osteotomes, I add graft material. And once I have everything raised, I place my implant in one time. The important part of this technique wasn't really very popular, but the important part is that this is the real first um, hydrodynamic pressure elevation system. Even though it wasn't very um, refined, it worked really, really well. In 2002, Toffler introduced SmartLift. SmartLift wasn't a really popular system, but it was the ground base for several other techniques. And the idea was to, in this case, use a trifine with stoppers and leave the bone inside. And then with the stopper placed in an osteotome, compress this remaining uh, subtracted bone, I could call it, and then add graft material in order to deform, elevate, and compress the sinus floor, and then place the implant, all without touching the membrane, and actually without cutting or just deforming the cortical floor. This was the base for several other techniques in the future. Years later, this technique was developed. This is the Versa technique. Uh, Notice that the only drill that goes clockwise is the pilot drill for the initial marking, and then everything goes the other way around in order to compact and compress and osteodensify. And it's basically the same idea of the smart lift, only mechanized. And you push and compress the bone upwards with the drills, and then you inject bone, this is basically a nova bone. You do it counterclockwise, very slowly. I always do it 50, 60 RPMs. And what you do is push the graft, just like you did with the smart lift, towards the apex and deform and compress without really touching the membrane. That's one of the similarities. And then you get this uh, alveolar site. You place your implant with normally very, very good stability. And well, in this case, you need to fix the defect. Uh, this is the Ostel, well, ISQ measurement 74, which is actually very good. And so grafting to correct the defect. And this is not nova bone, it's a particulate. Very simple procedure, very, very fast. And then stock abutment, sutures, and the position of temporary. So correction of the temporary by taking out the stock abutment and correcting the emergence profile, as we all do, and reinsertion, occlusion, and you're done. The Versa technique presented earlier was introduced in 2012, 2013. But this one from Kfir, also from Israel, was presented 2005, 2009, depending on several things. But basically is with contact to the Schneider membrane, and consists in the introduction of a fully collapsed balloon that will be inflated in contact with the membrane with saline, and it will use some elements of hydrodynamics in order to elevate the membrane and create a pouch that you will later uh, graft and place the implant. Originally designed by Hoekman, this technique was very, very well designed, and it was very popular with Zimmer users and alpha value users. But why? Because it had very good post-op, very predictable, and it was actually a very well-designed technique, originally intended to be the placement of the implant in a second stage surgery, but with modifications and improvements, became a one surgical time technique. And the only complication, the problem actually in the complication, is that it was very expensive. Balloons were expensive. You had to have a manometric pump, which was very expensive, and cables and everything was, well, that made it fall a little into disuse. But all in all, it was a very, very predictable technique and used, as I said, elements of hydraulic pressure, controlled hydraulic pressure, which is where most techniques went from there. As you can see here, the balloon pops up vertically, uh, concentrating the forces on the membrane. But if you watch on the right, you can see that uh, the arrows point to the peak stresses, and those are far away from the balloon, which is very good because this allows a gentle elevation of the membrane unless there are anatomical complications that could prevent the mobilization of this membrane. In 2005, Soterakis presents this hydropressure technique, which is derived from Causy's initial technique, where with a syringe adapted to the osteotomy, you push the saline through the osteotomy in order to separate the membrane and then pack and graft and install the implant. This technique had several complications. The first one is the partial adaptation of the nozzle to the osteotomy, and that prevents the equalization of the pressure. That means you get peak stresses on the membrane exactly where the flow comes from, and concentration of these peak stresses will lead or will possibly lead to bursting of the membrane or perfs in the membrane and later problems. But this technique was the base for several others. Chen and Cha presented this other variation from Causy's technique using high-speed velocity handpiece with air and water pushed into the osteotomy. But the lack of control of the flux tended to generate perfs in the membrane, and that would bring problems later, although this technique is still in use. As shown on this article presented on May 2020 by Cha and Chen, they still use this technique. And I have some issues with this because if you read the surgical procedure, it says using high-speed handpiece, after which a stream of water under hydraulic pressure was delivered on site via high-speed dental handpiece at the highest possible pressure setting until sinus burr passed the cortex of the sinus floor. There is no mention of diameters, no mention of real pressure, water flow, volume. So too many things are left to chance at random in order to be a predictable technique. And well, the symbol of pretty much all unequalized hydraulic pressure techniques is the burst of the membrane at the contact point with the water flow, a high-speed water flow. This image is taken from a finite element analysis of the unequalized hydraulic pressure techniques. And you can see right there on the red, the concentration of pressure is in the apex, right where the water flow touches the membrane. Even though there's a bone disc right there that is somewhat protecting and helping diffuse these pressures. But if you think about it, Tản Đà's technique does not have a bone disk because they grinded it off. So the water flow hits right there and the concentration is there without any diffusing. So that is why probably most of the perfs and bursts occur right there. And we arrive to the equalized hydrostatic pressure variant, which is an improvement because, well, these controlled hydrostatic pressures variants are based on a closed circuit where you don't lose any fluids, and that helps distribute the pressure around all the membrane without creating source points. Source points or apexes are where the pressure concentrates and tends to create bursts. So this technique was designed originally for piezoelectric techniques, and you had to have a special set and a water pump that was manometrically calibrated, and well, this all led to costs, and that made this technique, even though it had really great success rates and very low post-op complications, to not being a very massive technique. Well, you get the idea. In 2009, Som presents the piezoelectric internal sinus elevation system, which is a piezoelectric set that had continuous taper. And so you drill up to the cortical and then you illuminate the cortical floor with your piezoelectric, and then with a continuous taper element of the piezoelectric set, you block everything and inject water, and this water is distributed correctly because it's a closed circuit, and so you get controlled, equalized hydrodynamic pressure and a softer elevation, and then you graft your sinus under your sinus membrane and place your implant, and great. But the advantage of this system is the elimination of source points or apexes where the pressure was concentrated because it's an equalized system. This is a layer variation of Son's technique with the use of several specially designed nozzles to create a closed circuit. And just by looking at this technique, you know it's complicated. And even though it's very predictable and has very good results, it was never very popular because, well, yeah, it's complicated, and we dentists don't really like complicated things because, well, let's face it, they're complicated, and when they are, things can go wrong. So simplify. That's what we want. This animation was taken from another company that, well, makes piezoelectric systems, and it's basically the technique according to Dr. Bertolotti. The flap that's being designed here, it's, I am guessing, just for show in order to clarify some things. So exposition of the ridge and initial osteotomy with piezoelectric, small diameter, then larger diameter, flat piezoelectric insert that goes up to the cortical, and larger diameter piezo that breaks the cortical and gets the initial separation, a small amount of grafting material, and the use of the same flat piezoelectric insert to push the material with a very big water flow in order to equalize the pressures, and then remotion of what's left of the cortical floor and packing of more bone material, more bone graft material through these flat piezoelectric with high water flow. This will create a closed circuit and equalize the pressures. This technique in this special animation is for 2 implants. So then you use the taper to ensure closed circuit and the shape for your implant in order not to overcompress. Notice that there's connection between both implant sites, some things that we will see in the future slides, which is something to have that is actually very important. And then you insert the implant that will, let's say, be fixated in the remainder of the bone and the rest inside your graft. And that would be Dr. Bertolotti's view. The Benex system was presented in 2010, and this could be a 2015 variant using the SLA or ESM technique from this. This is a Korean company, but basically what they are doing is taking the lateral window up to the ridge. And so this is from a Korean company that goes for the desk system. So initial drilling up to the cortical of the floor, and then you go for the desk drill, and you will feel a slight drop. And so then you separate with periosteal layers and you graft and you place your implant. And so in real life, it would look pretty much something like this. H-flap, rich exposure, and then you go for the initial drill, secondary drill, final drill, and then you go for desk with stopper in order not to perforate. And it says right there, you will feel a slight drop, something I wouldn't like actually. So you remove everything and then you enhance or widen your osteotomy. They use a special drill which helps you open up more your osteotomy. It's a very special drill. You remove all the chips. In order not to perforate the membrane, you check for the stability of the membrane, which seems fine. And then you graft and elevate slowly, and then place the implant, and then primary healing screw and suture, X-ray, and you're done. This is an Austrian technique by Palmer and Vacek, and well, you can see that this patient had an under sinus elevation on the other side, and there is remnant bone. So the idea is that this is the mother of all newest sinus elevation techniques using equalized pressure. So guided surgery. Now you install your guide, tissue punch under high irrigation, number 1, and remember you will not perforate. Number 2, and you go for the second tissue punch. And this is the actual novel guide system. So gun drill, irrigated gun drill with stopper. You go in full, and you can see on the right that there is no perforation. This is an endoscopic view. You remove, and this one is the important part. This needle has a stent type balloon, collapsed balloon, and on the tip. This balloon allows you to inflate it. This needle inflates the balloon when you rotate the ball, and this allows you to get a sealed osteotomy. And with the sealed osteotomy, you get equalization of the pressure. Now you attach your syringe. This is a gel, actually, not a saline or any other kind. It's a special gel, and you see the manometric valve and manometric pump you remove. Now you go for the second gun drill, and you will see that liquid comes from the one in the front. So you seal, again, using the same needle, attach your syringe, and inject gel. Since it's a gel, it won't come out from the other side. So you use your manometric pump, and once you're done, you, again, deflate the balloon, break the seal, and remove the needle. So now you remove your guide and check with an X-ray. The gel is also has radio contrast, so you can see it. Now you have to remove the gel, which is actually done with saline. So we go back to saline, and you can see the contact from the front to the posterior and back. Once you're done, you start your graft. This is a particulate, and once you have filled all the cavity with all the bone you're gonna use, and this is something you need to see. We'll check it out in the end. Now you compact in order to get a clean canal and ensure the bone is right there, and you go for the implants. This is one of the defects of this technique. It tends to use short implants. This is a 10mm implant, and for something this complicated and this expensive, I think 10mm, it's maybe not the ideal. This is something that I like from DIVA. The smaller implant we get is 11.5, which is very good for me. It's a very good implant. And now you place the secondary implant on the back. And since you use tissue punches, you don't need to suture, so you place your healing abutments. And so a week later, control an X-ray shows that everything is perfect. And so also CT, and this is what I mentioned. You can see the very large amount of bone and very high disruption of the maxillary sinus, even with maybe some involvement of the osteomeatal complex. That wouldn't be nice. But the technique is actually very complex and very good. And if it's so complex and so expensive, why? Why would you do this? Well, this is the answer, actually. You see this finite element analysis? There is no pressure. The pressure is completely equalized, and it's so low, it's blue. Blue means pretty much no pressure. And so you can get a very good sinus elevation without source points or apexes. And that means you will probably never have a burst of your membrane, and you can elevate very, very confidently, which is what we want. No problems, confidence, predictability. Based on all the accumulated knowledge about equalized hydrostatic pressure, there have been several systems developed in order to make use of this. This is one. This is the IRACE, which has a variation of the DASC system. You see there is contact with the membrane from the verb, and then you insert the implant. This implant creates a closed circuit, and then you can use liquid hydrostatic pressure to elevate the membrane, and Yes. Uh, Now, I have several issues with this system. The first being that the emergence of the liquid is purely apical, and that means you have to eliminate the bone disk, or there is no bone disk, and also there could be contact between the rotating apex and the Schneider membrane. Second, the canal is lateral and there is no real uh, closing or isolation. You are at the mercy of the anatomy. And number three, this is a type of a parallel wall implant, which means you need more bone to stabilize it in the beginning. But the uh, point that I always make is that you cannot touch an implant without leaving something behind. In this case, debris, plastic debris, or cross-contamination. And this area is not the best, actually. You don't have any much bone, and you cannot risk any kind of debris getting into your implant. That will disturb your osseointegration. So we finally get to DIVA, dynamic implant valve approach, and this system is a minimal invasive transcrystal sinus elevation system using hydrodynamic pressure, equalized hydrodynamic pressure, and the advantages of this system are a conical implant with great macrogeometry stability, uh, exhaust ports that are apical and lateral, which means you will get your water sailing or whatever you're using in contact with the membrane and will elevate nicely. Also, those ports allow you to inject your graft material, and you can have your bone disc, which will protect the membrane from the rotating apex of the implant. And the most important thing, the valve. The valve screw is completely sealed and isolates um, the sinus environment from the mouth. You will get very nice results and very predictable results with this technique. We'll see that on our next lecture. And so I want to thank you again for enduring this lecture, and I hope to see you really, really soon on our fourth installment and final. That will be all about DIVA. Hope to see you soon.